Hi, everybody. Good morning, good evening, good afternoon. Wherever you are, I'd like to welcome you all to this second journal club by the International Academy for Clinical Hematology. For those who are not aware of this initiative, I'd like to highlight that the journal club, the IACH Journal Club, is supported by a very generous, unrestricted educational grant from Takeda Oncology. Just for the sake of introduction, again, I'd like to emphasize why a journal club. I think all of us would agree the medical literature is growing very fast, and we need to have a critical evaluation of the available information and try to digest in a timely manner the huge amount of knowledge being generated every day. And that would allow to expand, to balance the physician scope, and that will help to improve and favor good clinical practice and state-of-the-art patient care. So one way to achieve such goals, and there are many ways to achieve these goals, actually is to go through a journal club. And during this journal club, and like every journal club every other week, the goal is to present a summary of the chosen paper, and the papers are chosen by the steering scientific committee of the International Academy for Clinical Hematology, and you are all most welcome to suggest papers and panelists. Then we will initiate a discussion, usually with two experts. One of them is an author or co-author of the paper, and another expert who is independent from the paper. And at the end of the day, the idea is to discuss, to debate the pros and cons, and see how this will impact the routine practice. And for today, we are on the 2nd of November 2020. We have chosen this paper just published on the 22nd of October 2020 in the New England Journal of Medicine, and the title is Dasatinib Blinatumomab for Philadelphia Positive Acute Lymphoblastic Leukemia in adults. And to debate this paper, we are very fortunate and honored having the first author, Professor Robin Foa from Rome in Italy, who will be joining us as a panelist. But also, I'm very pleased having Dr. Eolia Brissot from the Sorbonne University in Paris, a close colleague, and who is also an expert in this field of ALL. So this is the summary, the abstract, and as you can see, it's about the validation of a chemotherapy-free induction and consolidation first-line treatment with Dasatinib and Blinatumomab in an adult patient with Philadelphia positive chromosome. So these are the main findings and data from the paper. Single-arm trial, 63 patient, median age 54. You can see the fusion protein distribution P190, P210. And before the patient received this induction regimen with Dasatinib, they received a pre-phase treatment with glucocorticosteroids for 7 days. Dasatinib was introduced at a dose of 140 milligrams once daily, and it was administered as an induction therapy for 25 days. Then all the patients who completed the induction phase received post-induction consolidation treatment with Blinatumomab at a dose of 28 microgram per day. And before each Blinatumomab cycle, they received dexamethasone. The primary endpoint of our trial was a molecular response, a complete molecular response, and a positive non-quantifiable response, like MRD positive samples outside the quantitative range, with induction therapy involving Dasatinib plus glucocorticoids followed by 2 cycles of Blinatumomab. So rather very straightforward, I would say, approach. And the results, although the follow-up is relatively short, the results are quite amazing, as you can see on these survival, overall survival, disease-free survival, but also cumulative incidence of relapse curves. So with this, I would like to start our discussion with our panelists. Thank you, Professor Foa. Thank you, Dr. Brissot, for joining us tonight. It's really a pleasure having you with us. So my first question is going for you, Robin. Can you tell us a little bit about the story of this trial? You know, how did you come with this idea? Of course, I've read the paper, as you may guess. I've seen the introduction about the rationale, etc. But I want to hear from you. How did you decide to proceed with your JITMU colleagues to run such prospective trial, please?
So, Mohamed, hello, and Dr. Brissot, hello too. Good to speak to you. Mohamed, we haven't seen each other for a little while, so it's nice to see you virtually now.
Almost a year we didn't see each other.
Sorry?
Almost a year we didn't see each other.
Yeah, that seems amazing, doesn't it, based on the frequency we had before in meetings here and there. So, no, thank you for the question, because this is, in fact, it's an interesting story, because I see this, as I've written to some friends or people, you know, that write, I see this a bit like, I can say, grand finale of a long story, because we started with this approach of trying to avoid systemic chemotherapy in induction of Philadelphia positive ALL over 15 years ago. So that's a long time. Why did we consider this? I mean, in those days, you know very well, we had the data for chronic myeloid leukemia. We know the impact of, we knew the impact of the TKIs. So it seemed logical to obviously extend the use of, well, in those days was imatinib, being the first TKI obviously developed also to Philadelphia positive ALL. However, we thought, based on the CML data, that maybe we could even try to avoid chemotherapy in induction. Because the data in CML was so good that we felt this could be a window of opportunity. Obviously, an ALL is very different from a chronic leukemia. This is clear. But to make it ethically acceptable, we decided that the first study would be designed for elderly patients with Ph positive ALL. In fact, the first study we did by the GMEMA, not the JITMO. I know you're very much transplant oriented, but it is a GMEMA in Italy.
Oh, sorry.
It's not. We'd be told off by the GMEMA. That's why I'm saying it. So to make it, the GMEMA is a corporate study group in Italy for adult hematological diseases. So the reason was that, as we all know, before the year of the TKI, the prognosis of adult Ph positive ALL was, to say the least, dismal. I mean, Dr. Brissot is young, but you're less young, Moti. You're very young, but a little less young. And we remember in the old days that if you had the Philadelphia positive ALL, this was more or less the worst diagnosis you could make. And maybe not only in hematology. I mean, I remember telling students, I mean, that possibly this is the worst cancer you could get, because in those days, the prognosis was a disaster. the only option was an allogeneic transplant, if you could in fact get to a transplant, because many patients did not respond to treatment, so you can't go to transplant with a full-blown disease. So that was one background. The other background was that we've learned over the years that, well, 2 points. First is that the Philadelphia positive ALL is the most frequent genetic subgroup in adult ALL, accounting, you read in books, 25 to 30%, while it's less frequent in children, about 2 to 5%. But also in children, they do very poorly. Remember another paper from Italy in New England, Maurizio Rico, showing that the only chance really was a transplant even in kids in the old days. So that was a background. And the other point is that not only it's the most frequent ALL subentity in adults, but it also increases with age. And in fact, now we know, and this has been published also by the GMEMA and the IACH of the adults and the childhood database in Italy, that the incidence progresses with age. So if you're a young adult, 18, 25, it may be 15, 18%. But if you're over 50 or 60, it's about 1 out of 2 B lineage ALL carrying the BCR-ABL. That makes it a relatively or very frequent, if you make a diagnosis, that's the key point. How many elderly patients are not tested? I put this for the discussion or for you to bring it up, Mohammed, later. I mean, how many 8-year-olds are tested for the BCR-ABL? I think that's a very important point. So the first study we did, as I said, goes back over 15 years. It was published in Blood in 2007. It was quite some time ago when it was published. It started 2 years earlier. Was for elderly patients. So we did a study with imatinib and steroids. And the induction was only that, plus CNS prophylaxis, but there was no systemic chemo.
So can I interrupt you, Robin, because you mentioned imatinib, and here in this study you're using Dasatinib. So why not nilotinib? Why not bosutinib? Why not ponatinib? And recently we've seen in CML flumatinib. So why did you choose specifically Dasatinib? I guess bosutinib maybe wasn't available at time, or ponatinib. So why Dasatinib?
That was a ramp up from the other study. The first one was with imatinib for the elderly up to 80 plus, and they all responded. Then the second study based on that was with Dasatinib. And again, we published that in Blood, and this was not for the elderly. Based on the very positive results, all patients went into remission, even being 70 or 80-year-old, with no death in induction. We did a study for all adult patients, 18 years up, with Dasatinib, and we got very good results. And interestingly, in that study, again, I said it's in Blood, we found that the proportion of patients obtaining molecular response only with Dasatinib and steroids, without chemotherapy. Then after the treatment was open. Then we did studies with rotating imatinib and nilotinib. We did a study with ponatinib, which has been presented at various congresses, and the paper will go out soon. Why did we choose Dasatinib? Well, I mean, I think a few reasons. One is that we used Dasatinib at least in 2 studies, and we were quite happy with the results and with the rate of molecular response. The second point is that you will remember that Dasatinib does activate NK cells. It has an effect on the immune system. So we thought that since the second part of the study was immunotherapy, we thought this could be an added value. And the third obvious point that we wanted to compare with our previous studies. So the initial induction is exactly the same as 2 previous studies, one published and one about to appear in the literature too. So that is more or less the reason why we did. So that is a story, Mohammed, that goes back a long time. And I must admit that in the early days, there was some skepticism around the world, because you treat an acute leukemia with Philadelphia without chemotherapy. But I mean, the data in the elderly was very good. And so we thought it was ethically acceptable. And to make this long story short, I mean, I don't know how many we have treated. I know 300-400 Philadelphia positive, and the rate of remissions without chemo and induction are between 94 and 100% hematological remissions. With virtually no death in induction, very, very few exceptions. So that was the starting point of all this. And then we go to the study, obviously.
Very nice story, thank you. So, Dr. Brissot, what was when this paper came out, and you deal a lot with ALL in general and Philadelphia positive ALL, what was your impression when you read it? What was your conclusion? Was it a sort of a wow effect? Was it, oh, we knew this? Or what was the impact?
So yeah, thank you to to ask me to be part of this ICH club and to discuss this paper.
So we're not hearing Dr. Brissot.
We've lost her.
Yes.
I think the result was already present at IACH meeting, so we were. Can you hear me? Yes.
Yeah.
Okay. No. Okay, it works. Okay, so this no, not good. Sorry for that. Two. Is it better now?
Yes, that's okay.
Sorry. Okay, so this your study were presented like last ASH meeting. So most of the physician was waiting for your paper, and it was really a wow effect, as Professor Motti says, because we can see in your paper that chemotherapy-free treatment with associated targeted treatment with Blinatumomab and Dasatinib is really safe with very low treatment mortality, and is very active because you have at 18 months overall survival, it's more than 90%, 95%, and DFS is 88%. So it's really quite, as we can say, it's quite a new era in the ALL approach now. So it's very important treatment paper for ALL.
Okay, can I ask a question? And obviously, when we look to the results of chemotherapy plus TK inhibitors, actually you can achieve a very high rate of complete remission and MRD negativity. So the question we had from many colleagues regarding this paper, as you may guess, is about the financial aspect, for instance, and say, well, is it really worthwhile since we can achieve similar results? And some of these patients still needed to proceed to allo transplant. So I'm trying to be here the devil advocate and say, why pushing for chemo-free, whereas you can achieve maybe similar results with chemo plus TK inhibitors? What are your thoughts, both of you?
Yeah. So, Mohamed, yes, this is, I understand the point. I think we should, to be very objective, comment that you can achieve similar results with chemo, more or less intensive, and TKI, but you are paying a price in terms of toxicity. I mean, we can turn it around as much as we want, but the true data show death in induction. They have to stop treatment, they have to be hospitalized, etc., etc. So, I mean, I don't have never seen any data, long-term data, even on our previous studies, showing better outcomes with this, let's say, conservative approach. So I think that is the first point. I mean, as you said at the beginning, many patients did most of their treatment at home. So we'll come back to that, because I think, just again to put it, I think in the COVID time, this is something, let's keep it for the end, but I think it's a very important point. Is so cost. Clearly, if we just sum up the cost of the drugs, it's more expensive. But I mean, what are the cost of hospital days, repeated hospitalization, antifungal, anti-whatever, all the treatment you have to give, you have complications. So I think we can't just sum up what the individual drug cost. I think it's a much more complex story. And then, I mean, transplant in most centers will be the obvious follow-up of a patient with Philadelphia positive ALL, which we may question or discuss in a few minutes. I don't know if that is necessarily the story. We feel, and this we will prove in the next study, that that many of these patients could be spared the chemo altogether and the transplant. So this obviously makes it also cost saving, apart from saving of many other aspects, toxicity I mean, I don't have to tell you, but you can die from a transplant, or you can have a very poor quality of life. So I think these are the key points to put together. I think it's a bit simplistic just to add up the cost of treatment without putting together the quality of life, the fact that patients are not in hospital, which has a cost, obviously.
So, Eolia, can I ask you a question? And I think, Robin, you made a very nice point about this issue of cost, which we always need to evaluate in a more comprehensive fashion rather than just looking into the price of a given drug. So are there now, I mean, without any financial consideration, let's say, and assuming all of these options are available, in your practice, based on these data, who are the patients who would be given this regimen, chemo-free, Dasatinib, Blinatumomab, and who are the patients where you would continue to give chemo plus TK inhibitors?
Yes, it's a difficult question. So I think for one data we're missing is long-term follow-up in the study. So when people go under transplant, the TRM is only 4%. I think we don't have this kind of data in any studies. So when you go to transplant, it's really interesting to have Blinatumomab plus Dasatinib. I think for older patients also, because if you don't go under transplantation, there are really low mortality and very less toxicity. So in fact, according to me, now we're really moving to less chemotherapy and more immunotherapy. And I think the major problem is accessibility, financial accessibility for a lot of countries. But for a physician, if we just don't discuss the price, with this kind of data and with the other data we've with the Tower study, Alcantara study, we know the safety, we know how to use Blinatumomab and also TKI, and we are very confident and comfortable to use them in our practice. So it's more a financial issue.
You mentioned immune therapy, and I'd like to go back to you, Robin, because you highlighted the immunostimulatory component of Dasatinib, and actually when we read carefully the paper, you have monitored, I think, a small group of 17 patients for
you read the paper.
Absolutely, including the supplement. Otherwise I won't be here. You know, Philadelphia positive ALL is not my cup of tea, so if you want me to moderate this, I need really to do my homeworks.
Congratulations.
Thank you. So you monitor this, and clearly you get rid of the regulatory T cells. But on the other hand, I was surprised that the incidence of CMV reactivation was quite high, almost 60%. So on one hand, you have an immunostimulatory effect, and on the other hand, it looks like you're losing like viral control with CMV reactivation. How can we reconcile this?
Okay, so this is a rather long, complex aspect to it. So, I mean, we gave data on the Tregs, and I think we gave some preliminary data also on CD4, CD8, but we have more data now because obviously we're studying more patients. I mean, the paper was submitted some months ago, so we have more data. This appears to be quite consistent. Tregs do go back down. But interestingly, again, I mean, we didn't mention this earlier because the data, I mean, the molecular response, the primary endpoint was after induction and 2 cycles of Blina, which are canonical 2 cycles. And there we got to about 60% of molecular response. But what is very interesting is that with more cycles of Blina, the rate of molecular response increased. We went up to 81%. It's something that is a bit surprising, and we didn't expect really, because in all the studies on relapsed or whatever, the large response is after 1 or 2 cycles. So this is very interesting. It might be that on very small disease, you need more cycles. Why am I saying this? I'm trying to tie this comment to what you asked, because we've seen that the Tregs tend to decrease after 3 or more cycles. So it may be that it's all a balance between the immune system and the cycles of a Blina that we're actually delivering. So I think that is a relevant point. to keep in mind. I must say that this is not obviously the primary point of our study. So we'll have more data. We are writing up another paper, I must say, on the immune status of these patients, but we have more information now. I think you had another question, but I've lost it. So maybe, did I answer or did I miss something?
You answered very well. Thank you. Eolia, are you worried about the safety or toxicity of this chemo-free combination? Because, I mean, when you look to the side effects, it's quite amazing.
No, I think we're not worried about the toxicity of the combination, because we know how to use Blinatumomab now very well, and there is only a few patients who have neurological toxicity. And Dasatinib is often used in CML also, and also in ALL or CML in accelerated phase. So the combination is, I think, quite easy to use in clinical practice, and is not really a problem.
So regarding Blinatumomab, we have a question, Robin, here from Dr. Alomari. Can we use Blinatumomab in these patients if they have a CD19 dim expression, low expression? What's your feeling about this?
Well, it depends what we mean. I mean, you know, in general, if there is a level, some degree of expression, we tend to use an antibody. In general, I'm speaking. I mean, we will all remember that there's even a study from the German ALL group where they give rituximab to all B lineage ALL patients, irrespective of the level or even absence of CD20. Because, I mean, you might have some level of expression of an antigen that you don't pick up by flow cytometry, so, or very dim. So I think that is one answer. Here, I mean, we wouldn't give it, obviously. I mean, it's very unusual that you have a B lineage ALL without CD19. I mean, this is by definition should not occur. Clearly, if a patient has had CAR-T before, then that could open an issue. I mean, but in our study, this would not obviously be, it wouldn't have been possible. I mean, in a real life, we would avoid giving it in a CD19 negative patient. If it's dim, I would consider it nevertheless, because dim is positivity.
Yes, dim is positive.
Can I make two comments, because there are 2 points I wanted to make. Dr. Brissot brought up something that's very close to me, and I know Mohamed too, because we travel and we go to many countries, the issue of accessibility. This, for me, is a very important point, so I would like to make a comment on what you very wisely brought up, because I think it's very important. I mean, you know, these studies, I mean, we have an academic hat, but we also have particularly with Mohamed, we meet in different parts of the world, and not only the rich countries. Obviously, all these things are doable in a minority of parts of the world. Let's be very honest on this, because even to set up all these studies, it's not only having the drugs, but it's also having all the laboratories. I mean, we have an organization, as in many corporate study groups, where all samples from patients are centrally processed. So, I mean, Philadelphia, you've got to pick up the BCR-ABL, so they have to be done. So in that window of pre-phase, steroid pre-phase you mentioned, Mohamed, at the beginning, that's where all the samples come to our center in Rome from the whole of Italy, and we test them within 1 week whether they have or they don't have the BCR-ABL. And according to that, they go in 2 different protocols. Then all the genetic landscape, it's all done on diagnosis. For the additional genetic abnormalities we haven't discussed, but are very important and will be in the next study, we did them all at presentation. So we have the sample all available and material stored away, which is important. All the MRD, again, is done centrally. It has to be done in certified laboratories with standardized technologies. If we're taking decision based on MRD has to be done in the best possible way. So there's something doable in certain parts of the world, in certain organizations, and not doable around the world. It's a point that I've made very frequently with the Amgen people, you know, that they produce the Blinatumomab. If Blinatumomab is approved for MRD, which is approved by FDA, EMA, etc., if it's approved and anybody can give it, you have to be sure that the MRD data is done correctly. I don't think it can be done everywhere in-house as it comes. You might decide whether to transplant or not transplant a patient based on MRD, and if this is not done correctly. So I think this point is very important, and we should emphasize this, that the management of the disease is very complex. And if possible, there should be networks in individual countries or regions to do it, which as you know very well, does not happen in most parts of the world.
No, I think I'd like to emphasize here that we at the International Academy for Clinical Hematology, and both of you are founding members of this academy, we are committed to the AAA goal, which is about availability, accessibility, and affordability of drugs everywhere, and to make them available to all patients in need. Obviously, we, with our academic hat, we do not control everything that's happening across the globe, but at least we keep an eye on the right direction and where we want to go. We have a question here, Eolia and Robin, about the CNS prophylaxis. So in this study, methotrexate, IT methotrexate has been used. Is this okay? I mean, we feel comfortable because these patients did not receive chemotherapy, which can penetrate, you know, into the CNS. Are we happy with this? Is this okay? This is a question from Dr. Shire.
We have a randomized study in children population, randomized methotrexate versus methotrexate and cytarabine for CNS prophylaxis, and methotrexate were done as well as the association. So I think it's enough to do prophylaxis with methotrexate, and we also know that Dasatinib can enter in the
blood barrier.
Barrier. So and you don't have CNS relapse in your study, no, Professor Foy? I don't think you had some. So
Robin, we lost you.
Oh.
Yeah.
It's not me this time.
He is back. Okay.
This back.
We are back.
Okay. So let me move now to the allo transplant subgroup of patients. So what was the basis actually for proceeding to transplant? Was it MRD driven? Because actually your rate of molecular response was so high, I would have guessed that no one should go to transplant. So was it about the anxiety of the attending physician because, you know, that wasn't validated, and then after achieving the primary endpoint, then physicians were able to decide?
Good point, Mohammed. Absolutely. Now, let's remember that the design of our study was such that the primary endpoint was after induction and consolidation. Treatment after that was open. We left it to individual centers, and we did that. I mean, we thought about it a lot. We thought it was simpler and the study was clear if we did it that way. So they could do what they want after the data post-consolidation. All the information is being accumulated in an ancillary GMEMA study. So we're gathering all it. So the transplant data, we decided to add it, although we don't know why they did it yet, we will know. We don't know the outcome. In fact, this data is not included in the study, but we put it simply because of what Dr. Brissot said, the very low mortality rate. There were 24 patients, which is not an enormous number, but it's not a small number either. And some patients were not kids, so I mean, not young adults. So it's certainly doable. So I can't tell you why they did it. I think it's probably what you said, because of the old conception that it's a Philadelphia positive allele. So since they've had a very good response, why don't they just transplant? So I think that is the main reason, but we'll get all this information. But what was very rewarding was that 4% of transplant-related mortality, which I interpret, or we interpret, as probably due to the lack of toxicity the patients have gone through because they have had systemic chemo. So that seems a logical explanation. Now, obviously, the question, which is the ancillary to what you said, is, should we transplant a patient that's in molecular remission? Sustained molecular, that I think is the key point. But we can, I don't know how long we have. We could go on hours discussing this point because there's no answer to this really. I mean, if we asked 10 hematology, I think probably 8 would say I would transplant. But I would like to make a few points. Now, one is that, as we mentioned earlier, Philadelphia positive ALL increases with age. So if you have a 60-year-old, I mean, who's gone into molecular remission sustained, I mean, would you transplant? I mean, I wouldn't, to be very open, because I don't think this is acceptable, because as we said earlier, you can have a very poor quality of life or you can pass away because of transplant. We've seen patients dying in earlier protocols in molecular remission, dying of transplant, and that's tough to accept. So I think we have to, I mean, be careful on this point. We'll see the data, because obviously if the data look good after 24 transplant, we may rediscuss it, although the numbers are small. But I don't know where your next question will go, because at the end, if we have time, I'll tell you we're going with the next study. I don't know, it depends on your question. So you see, we haven't, no, that's the important moment. Tell you that we haven't prepared it in advance.
No, absolutely. And actually, it's not pre-recorded, Guy. We are really broadcasting live from Paris, obviously virtually.
Yes, it's true.
So this is why we have technical glitches and so on. So we have, regarding this MRD issue, we have a lot of questions. We have Dr. Noguera, Dr. Razan, Dr. Ramlal, hopefully I'm pronouncing well, asking question about patient who lost MRD negativity and progressed. And there is a subgroup, I think, in the paper where you detected the T315I mutation. So what happened to these patients? How did you handle them?
So again, let's remind our audience that the study was all induction consolidation. What we did do is, in monitoring MRD, when we saw an increase in MRD, we were all in remission, but if we saw an increase in MRD, we tried to investigate whether there was a 315 mutation, because we know that Dasatinib can induce this. It's something that we've all seen and we know. So that is what we did. And we did find that a proportion of patients with an increase in MRD during induction, so this is under Dasatinib, before Blina, there were a few patients who had an increase in MRD levels. They were still in hematologic remission, increased MRD levels. So we tested for mutations, and as written in the paper, and I guess this is why they're asking, some of the patients indeed had a 315 mutation. These patients all went to Blina. And what was interesting, again, something we didn't expect, they all became negative. So they became negative and they lost the mutation, obviously. So that opens another point that this is, let's say, it's an ancillary finding from our study, that maybe the addition of Blina may reduce the risk of a 315 relapse, which is one of the worries when using Dasatinib rather than Ponatinib, maybe. So I think this is a very important point. Now, I don't have the data later, obviously, yet, because, as I said, the study finishes with the consolidation. That was the endpoint. So we'll see after what has happened to the patient. And obviously, we are continuous to study the patients biologically, too. So the study still goes on. So I don't know what happened after end of consolidation. I don't even know after transplant what has happened. But this, I hope to get data and share them, obviously, as soon as possible.
So here, I mean, you mentioned Ponatinib, which we always, mention to overcome the T315 mutation. I thought that Dr. Jabour published an initial chemo-free study from MD Anderson in Philadelphia positive elderly ALL patient. But I thought also, I mean, it's very delicate to compare head-to-head these different single-arm studies, but his results, the MD Anderson results from Dr. Jabour, were less attractive, I thought, with longer follow-up than these results. Do we have an explanation for this? Because Ponatinib is supposed to be more powerful or more potent.
Yeah, that was, if I remember well, Ponatinib with chemo, though. Is that correct?
Yes,
I don't think
chemotherapy.
So that, Ponatinib is certainly probably more active. It may be a little bit more toxic. So if you start adding Ponatinib to chemo in elderly, I mean, I'm not surprised that the data are not, I mean, are maybe less good than expected. Now, as you probably know, the Anderson is doing a chemo-free study similar to ours, but they're doing it the other way around. They're starting Blina first and then giving Ponatinib. But the data are not there yet. So I think the scenario is changing. I mean, I certainly in an elderly patient, based on these data, I would really try to avoid chemo as much as possible, and then we can discuss which inhibitor is better. But we have no direct head-to-head comparison, so it's very hard actually to decide which we should give. So I can tell you what we will do in the next study, maybe. But
so before you tell us what are you doing, Eolia, do you feel, because we have several comments about this, do we feel that we need a randomized trial to move forward with this chemo-free regimen, or I think we have sufficient evidence to propose this kind of regimens to a great number of patients? Although I think we have a comment from the audience saying that there is an ongoing randomized trial of Ponatinib hyper CVAD versus Ponatinib Blinatumomab. My guess this is the MD Anderson one. So what's your feeling, Eolia?
I think for the short follow-up for overall survival, disease-free survival, and toxicity, we don't really need a phase 3 study, because we when we compare, we have a lot of results with chemotherapy and IACH, and for OS and DFS could be quite the same. And toxicity is better with only chemotherapy-free treatment. But we don't have data for long term. And also for patients who have IKZF1 deletion with other cytogenetic aberration that had lower overall survival than the other, maybe chemotherapy can be useful in this kind of population. And also what is the impact of allogeneic stem cell transplantation? So there are still many questions we have to answer to be sure in which population we can use chemotherapy treatment for the long last term, in fact.
So here we have a nice comment from Dr. Jackie. I think she is in Belgium, but I'm not 100% sure, but I'm sure she is in Belgium. Hi to all my friends in Belgium, where actually in this terrible COVID pandemic, this combination without any phase 3 trial randomized is really very attractive, because as you mentioned, Robin, it can be done at home. They need just to come to change their Blinatumomab bag, and it's rather safe, and they don't need rehospitalization frequently. So, Robin, what are the next steps for you?
Can I first make a comment on the COVID story, because we're all living obviously a very difficult period. Now, as you know, Italy in Europe was the most heavily hit country at the beginning of the wave of the pandemic back in, say, February, March, April. Now, when we looked at the data, what is of interest, I think, is the fact that in this protocol, patients managed to continue treatment throughout the peak of the pandemic, which in Italy was extremely hard, particularly in the northern part of Italy, and obviously the centers are, I mean, Sandro Baldi is there, and he's in Bergamo, and Bergamo is one of the most heavily hit parts of Italy. And so these patients, for reasons that we both said, managed to continue treatment because they were doing it largely at home. And we never closed our laboratory, so the samples arrived and we could continue with the MRD, which was a key point, because if you didn't do the MRD, I mean, it would have been a failure of the study. So I think this should be underlined, particularly now that infection is rising everywhere, and the hospitals it's very contagious now. It's changed probably. It's very contagious now. So we're seeing bigger numbers, maybe less acute, but bigger numbers. We had very few patients with hematological malignancy symptomatic for COVID in spring. Very, very few. I mean, in the Philadelphia PODLL, and we wrote this up in the British Journal, we have 1 out of 200, and I can't remember, 70 patients. Philadelphia PODLL COVID positive. symptomatic of in those days we're not testing the population, it's symptomatic of. In CML with the same genetic lesion, very few, very few. I think out of 6,000 or 8,000, I can't remember, we had 12, practically zero, and we wrote that up in leukemia too, and it holds true now. So I don't know if this is to do with the type TKI, but we're opening a different. We can have another webinar maybe on this, but it's a very important point now. So I think this is very relevant. If we can reduce the hospital days, then this is obviously something very valuable. I mean, okay, so that I managed to say. For the future, well, I can tell you what we've written the new protocol. It's not open yet, but I hope it will be soon. And that interestingly takes up some of the points that both of you have been raising and that we've discussed. Now, randomization. This is a tough one. I mean, you brought it up because there are no randomized studies so far in the literature for many reasons. I mean, ALL is not a frequent disease. Philadelphia is a subgroup, so it's a rare disease. You would need a European or world study. Having said this, and I must say it's been very tough for me to digest, but we've decided in a new protocol to do a randomization. I'm saying it's tough because it goes against what we've been doing for 15 years, but we did this because we feel that even if we pay a slight price, if we want to formally prove and convince everybody that we can avoid an induction and maybe induction consolidation systemic chemo for the benefit of patients, but that's what we're actually talking about, I think we need a head-to-head comparison. So we decided, and so that goes, what will the control arm be? Because, you know, again, we're talking about Dasatinib. Dasatinib is not approved in most parts of the world for the first-line treatment of Ph-positive ALL. I think it's approved in Australia, and I don't know if there's some other country. So if we use it, we're using it off-label, which we are not authorized in Italy, and I don't think in France either. In some countries, you can use off-label, you pay and you can take it. But for us, this would not be acceptable. So the control arm will be with imatinib, because that's the drug approved for frontline treatment of Ph-positive ALL. So we'll do, as I said, it's tough to digest, but we're doing it. We'll do one arm with imatinib and relatively, let's say, intermediate dose chemotherapy. So we're going to do a conventional approach with some safety rules. It's going to be a 2-to-1 protocol. So 2 are going in the, I'd say, chemo-free arm and 1 in the chemo or imatinib. And if the response are not good, we're going to do a rapid crossover. So that would be a safety rule. So what's going to be the primary arm? The primary arm is inevitably we have to move on and test the TKI we mentioned earlier, Ponatinib. Because if you get, I mean, we have a paper that's not sent out yet, but it's been presented with Ponatinib frontline for elderly and unfit. And the molecular response rate with Ponatinib alone is in a range of about 50%. So it's higher than with Dasatinib, as based also on other studies in the past and on in vitro data. So we're going to use Ponatinib and then Blinatumomab. So the backbone is exactly the same, but we're using a potentially strong inhibitor. We might decrease the dosing. We're going to be very careful because, you know, the 45 may not be necessary. So that's part of the study. Transplant. So we come to the other very important point. We're not randomized because the numbers are not sufficient. A transplant will be omitted for patients who have a very good molecular response, have a deep, profound, sustained molecular response. Talking about MRD, we're talking always by quantitative PCR. I'm saying this because in many studies across the Atlantic, it's still flow. So there's a quantitative PCR, and we are, at the same time, we'll be doing digital droplet PCR next generation to try to further refine the molecular monitoring. So patients who have deep and profound sustained molecular response and do not have additional unfavorable genetic abnormalities, the landscape at diagnosis, even if they have a sibling donor, will not be transplanted. They'll be monitored and won't be transplanted. So transplant will be given to patients with a suboptimal molecular response and or with additional genetic abnormality. So it's not a randomization, but a stratification. And it's a large study with, I think, almost 300 patients, and we hope to start it well. And if that works, I hope we'll give the answer some of the points that you very correctly raised just a few minutes ago.
So, Eolia, would you be willing to include your patient in this trial?
Yes, yes, I think we'd be very interested to include them in this trial. Yes.
This is, well, definitely we need such trial, but I agree with you. I think the philosophy of what we are doing is really about decreasing the toxicities. And I think you pronounced this word earlier in this journal club about the quality of life of the patient. And in general, you would feel better at home, I think, with these gentle and mild treatment. And even if you are keen on transplanting them, definitely after this softer, I would say, chemo-free induction, you're generating less toxicities, because obviously 4% of transplant-related mortality, this is really relatively low, and the follow-up is 18 months. So we don't need to wait forever. You know, we're clearly on the very, very low side of transplant-related mortality.
Mohammed, it's interesting because, I mean, this is a small study if you think about it. 63 patients, as you mentioned, it's a phase 2, but the New England bought it. And obviously there was something there because this is not a large study. It couldn't have been really at the time, but so that is why we're trying to do this very ambitious large study, which should answer some of the points that we discussed today, and I think are very interesting. I had one more point I want to say, but I forgot it. Naturally, it'll come back later. When we finish, it'll come back.
Well, my kind request to you, Robin, is that maybe in a couple of years to have the long-term follow-up of these patients. And that would be, in my opinion, a key data, because that will maybe influence the inclusion and the performance of other randomized trials. But now we're running out of time.
Okay.
I think both of you were absolutely marvelous. I think we are really living in a new revolution in the hematology field, and probably conventional chemotherapy is almost ready to retire. That's my gut feeling. So it's highly deserved. So these chemo-free regimens, in addition to the immunotherapeutic approaches, are really making a big difference in these high-risk patients with usually very detrimental and poor prognosis. I do apologize to all the colleagues who sent questions. I looked into the dashboard. I had maybe more than 30 or 40 unanswered questions, but unfortunately, all good things need to come to an end. And so thank you very much, Professor Foa. Thank you very much, Dr. Brissot. One last word. I can see you are very eager to say something, Robin.
No, just following what you're saying, Mohammed. It's very nice. It's very informal here. I just wanted to remind the colleagues. I mean, there are probably a lot of young colleagues in the audience. I mean, in the old days, chronic myeloid leukemia was a lethal disease. Let's remember this. I mean, now patients with a TKI live more or less like the normal population. This is something that exactly. I mean, when I was young, this was unthinkable. It was a lethal disease. Inevitably, we go into an acute leukemia. Second, acute promyelocytic leukemia. That was a dreadful disease when I was young again. And now you can cure it without chemotherapy. So we have very practical examples. This, we hope, will be the third one. So we're working on this. Thank you again, Mohammed and Eolia, for joining. And for inviting me, Mohammed, for joining.
So the take-home message, and I think we really need it today with all of this COVID pandemic everywhere, and we always think about the patient, about the families, and everybody who's suffering everywhere from this pandemic. The key word for ALL, for hematologic malignancies, but for all of us is hope. And I'm really very optimistic for the future. So wherever you are, thank you very much for joining us for this IACH Journal Club. I hope you have enjoyed it and hope to see you soon. And in the meantime, please stay safe and keep well. Thank you very much.
Thank you very much. Thanks.
Thank you, Mohammed.